Good morning. Today we talk about chest injuries and how to assess and manage them. Our objectives for the day are identify the organs or systems involved with chest injuries, list the signs and symptoms associated with the following injuries or conditions, and I'll let you take a look at those there, and then we will go through each one of those. Some of them I know you have seen in pathology class, but we will cover them briefly in this course just as a review. Given a case study, a patient with any type of chest injury covered in this class, the student will be able to determine what caused the injury, whether it's blunt force trauma or penetrating wound type injury. We will talk about specific injury assessments to determine nature of the injury. We'll create a plan of care for each type of injury, and we'll identify the hemodynamics for each type of injury. So as you can imagine, the definition for chest injuries would be any organ from the diaphragm to the clavicles that is injured in any way, shape, or form. So you could have a blunt trauma, such as a car accident where you hit the steering wheel, or where you fall off a ladder and hit the cement. That would be blunt force trauma. Or you could have a penetrating trauma, such as a stab wound or broken ribs that puncture the organs. I've tried to draw this out for you so that you can kind of see where we're headed in this direction. First, we have the ribs. So if we think about the primary causes of rib fractures are typically going to be your blunt force traumas. So we need to address pain. Pneumothorax, we have to look at the chest x-ray and see if there's a pneumothorax present. And then we also want to assess for the presence of flail chest, where the ribs go the opposite direction in which it is expected to go. The next area of injury we're going to look at are the lungs themselves. So we'll look at pneumothorax and we'll look at the chest x-ray to determine that. Typically those are stab or penetrating wounds, but also can be caused by a blunt force trauma. So we'll look at the chest x-ray, we'll be determining the need for a chest tube, and then we'll also look at pulmonary contusions, bruise to the lungs. Even though they're pretty well protected by the ribs, you still can get bruised lungs. So we'll talk about the supportive care needed for that condition. We'll also talk about heart injuries, again, contusion or bruise to the heart. Again, it's pretty well protected, but you can still get hit hard enough that you'll have a bruised heart. We'll look at the EKG changes on that. And then finally, we'll look at aortic injuries, specifically the abdominal aorta, and what happens in that case. So we'll look at whether it's a transection or a leak or a weakness in that area. So we'll take a look at all of those areas of injuries. So if we start by flail chest, we talked a little bit about rib injuries or rib fractures. So the definition of flail chest, and I'm sure you remember this from pathology class, but the definition is failure of or fracture of several consecutive ribs in more than one place across that rib. So you can see that circled area there. About rib 3, there's a multiple break there. Rib 4, there's a multiple break. Rib 5, there's a multiple break. Rib 6, there's a multiple break. So it's created an area of instability. So as you breathe in, the ribs will go the opposite direction in which you would think they would. So watch for those flail movements or watch for that flail chest. With that, we're going to have to watch for pain management. We're going to make sure they have their pain under control, because if they don't, then we're going to have issues with atelectasis and potentially pneumonia. So we need to watch for that. We also want to watch for secretion management, because if they're not able to take big deep breaths and cough, we're going to have a secretion buildup. So we want to be careful about that. We also want to look at atelectasis. Again, like we said, or like I said earlier, if the patient is in too much pain, they're not going to cough and deep breathe, and there's a potential for atelectasis. So to take a look at all those things, we're going to use our chest x-ray, we're going to monitor our ABGs, we're going to look at our pulse oximetry, and in those we're going to look for CO2 retention or respiratory acidosis. We're going to look at increased dead space or reduction of alveolar ventilation, and then we're going to manage their compliance. So if they have a compliance issue, we'll need to ventilate them or have them on ventilatory support so we can monitor that a little better, and we can also offer them that support they need to let the ribs rest and manage their pain a little better. So we've talked about definition and causes, so I'll let you take a minute and write the definition down and write the causes down, and make sure to come to class with those answered tomorrow. Okay, what do you think a patient feels like with this type of injury? So I want you to write down what you think the patient feels like, and again, we'll discuss this in groups in class tomorrow. So if you're working in the ER, think about all the things that you need to assess on this patient. So think of your basics. Think heart rate, respiratory rate, breath sounds, temperature, SpO2, blood pressure. Think about all of those basic assessments we do on every patient. And then what other assessments do you want to do for patients that come in with specific chest injuries? So I'll give you a minute here to write down as many ideas as you can. And then next we're going to talk about how do you treat a flail chest. So think about your treatments for flail chest. Write down any ideas you have, and then we'll talk about them in class tomorrow. Okay, then we're going to move on to tension pneumothorax. So as you recall from pathology, a tension pneumothorax is an extension of a pneumothorax where now you have a one-way valve that's been created, so you can see the hole in the lung there. It's letting the air out into the pleural space, but then there's nowhere for that air to go. So we've created a one-way valve, and that pleural space just keeps getting fuller and fuller of air. So as you can see, that compresses the heart. So we're going to have a compressed heart, we're going to drop our blood pressure, we're going to increase our CVP because of the pressure around the heart, and then we're going to drop our cardiac output because the heart can't contract and expand like it should. So then we're also going to have a tracheal shift to the unaffected area, so that trachea will shift over to the unaffected area, and then the excess air in the pleural space is also going to cause compression on the unaffected side. So you're going to see the chest on the affected side get bigger and bigger and bigger, and the chest on the unaffected side is going to get smaller at first because it's going to compress the lung space, and then as that tension pneumo grows, the air can shift over to the other side as well. That's called pendulift, where the air shifts from one side to the other. So you may hear that term, pendulift, when you're in clinical. So remember, the air gets into the pleural space and there's nowhere for it to escape. So it's going to cause compression of the heart and lungs, and then it's going to shift the trachea and also cause compression of the vessels. Okay, so what does a patient feel like with a tension pneumo? So write that down. Give yourself a couple minutes here. Write what you think their signs and symptoms are. And then we'll talk about those in class. And then think about what are some causes of a tension pneumo. What could potentially cause a hole in the lung tissue? Okay, assessment and treatment. We talked about hemodynamics. So remember, with hemodynamics, your cardiac output is going to decrease, your CVP is going to increase, and your cardiac output will decrease. Blood pressure will decrease, heart rate will increase, SpO2 will decrease, respiratory rate will typically increase. Okay, and think about anything else you want to assess. What needs to be rapidly assessed on this patient? So think about level of consciousness, think about lack of oxygen to the brain tissue because your level of consciousness may change. Patients may initially be anxious and restless. That's a bad sign when you see patients with these that are restless because that means they're not getting enough oxygen to their tissues. And then how are you going to treat attention pneumo? What's the most rapid way to treat attention pneumo? Does anybody remember from pathology class? You're going to do a rapid needle decompression between the second and third intercostal spaces on the affected side. So you'll take a needle with no syringe attached and you'll just let that air out. And then if treatment isn't initiated immediately, what can potentially happen to this patient? Think about your lack of blood pressure, think about your lack of cardiac output, lack of oxygenation, think about all of those things and what will happen to your patient if it isn't immediately treated. After that immediate needle decompression, the patient will probably require a chest tube insertion at this point. All right, pulmonary contusions. I know this is a picture of PET or from a PET image or a veterinary clinic, but it does show good contusions. See how the darkened areas on the left side of your screen, there's that darkened area at the base and then the darkened area on the other side of the lungs as well. So you can see a good bruise here. So pulmonary contusion is defined as a bruise to the lung tissue, and then you can think in your head what causes pulmonary contusions. Would it be a blunt force trauma or a penetrating trauma? Signs and symptoms, what will your patients feel like with a bruise to their lung tissue? How will they breathe? Think about what anatomical alteration will occur with the pulmonary contusion. Think atelectasis. And then we're going to think about pain. We're going to think about shortness of breath, all of those things. So those are all things that are going to happen with your patients. Okay, hemodynamics. What will happen with your hemodynamics with a patient with a pulmonary contusion? Think about the stages of pulmonary contusion and then the severity of the pulmonary contusion. So will it affect your heart rate, blood pressure, respiratory rate, cardiac output, CVP, all of those things? Think about what will happen. And then what else would you like to assess on this patient, whether lab testing or imaging or anything else like that? What would you want to assess on this patient? And then how are you going to treat this patient? Is there anything other than supportive care you will do to treat this patient? And then what are the long-term effects of pulmonary contusions? Hopefully long-term effects will be minimal. They could have some atelectasis and some pulmonary scarring on those alveoli that were injured, but potentially that wouldn't show up for 6 to 12 months. So in the short term, they're probably going to still have pain. They might have some atelectasis, which would result in some shortness of breath, but in the long term, they may have some pulmonary fibrosis type injuries with that scar tissue around there. All right, tracheobronchial injuries. As the name states, tracheobronchial injuries happen in any of the areas that are shown on this diagram. So could be the trach, could be any of the carina, could be any of the surrounding bronchial areas there. Okay, so that's the definition. What do you think causes these injuries? What do you think the number one cause of a tracheobronchial injury is? Typically, intubation is high on that list, and then penetrating injuries such as stab wounds or fractured ribs where the ribs can be displaced and cause a puncture to the tracheobronchial tree. How will the patients know? How will you know this patient has a tracheobronchial injury? What are some signs and symptoms? What are some imaging results? Things like that. What will you find with these patients? Okay, we want to take a good history. We want to see what they've been doing in the last 24 to 48 hours. Were they recently intubated? Did they have a stab wound? Did they have a blunt force trauma? Any of those types of things, we want to do that. And then you can think about how they will feel. So hemodynamics, think of the stage and the severity of the injury and what effect will it have on the heart rate, blood pressure, CVP, those types of things. And then what are you going to assess on your patient? We know what we're normally going to assess, but to assess a patient for a tracheobronchial injury, what are some things you're going to look at? And then what would be the best practice to manage this injury? Typically, they will let the patient rest. They may have to re-intubate or trach the patient and let that area heal on its own. Kind of the rule of thumb is if it's greater than 1 centimeter long, if the injury is greater than 1 centimeter long, they will take them to surgery or to the bronchoscopy suite and try to repair the injury that way. But if it's less than 1 centimeter, they will just caution the patient to try and not cough too much. They'll try to just let it heal on their own. And then are there long-term effects from this injury? They could have some scar tissue surrounding that, which would could cause some complications if they were deep breathing or coughing, again, depending on how big the injury was and if there was multiple injuries or just a small injury. Esophageal injuries, again, you can define this on your own and think about causes. Think about inadvertent intubations to the esophagus. Think about aspirating food. I took care of a patient once that had gone to Mexico to get treatment for breast cancer, and one of their treatments was to grind up peach pits and give them to the patient because of the cyanide inside the peach pits helps in healing. Well, when the lady got back to Nebraska, she didn't have a peach pit grinder or anything to grind it up, so she swallowed it whole, and of course it got stuck in her esophagus. Well, then she was too embarrassed to go back to the physician and tell him what she had done, so she got septic from that because it caused an infection right there. She was unable to eat or drink for about 7 days, and then she finally went in, and by that time she was so severely septic from the infection around the spot of injury that she ended up passing away from being septic and not from the breast cancer. So do a good history on these patients, figure out what the cause was of the esophageal injury. Other causes can be radiation to that area. Sometimes if they have lung cancer and they do radiation, it will affect the esophagus. So think about that. Do a really good history on your patients and try to come up with some other causes on your own. Signs and symptoms, like I said, the patient I took care of, she wasn't able to eat or drink for a while. They will probably have to do a endoscopy of some sort to look at the actual area of injury, but signs and symptoms are typical of pain to that area and then unable to eat or drink. Assessment, what will you need to assess on these patients? So think about that. Think about where the area of injury is and what will be the best way to assess this patient. And then again, how are you going to treat this patient? For the most part, again, if it's greater than 1 centimeter, they will take them in and surgically repair it. They also may have to put in a feeding tube or a PEG tube so that the patient isn't actively using their esophagus. Herniated diaphragm, that is a weakness in the diaphragm where the abdominal contents move into the chest wall. Causes can be congenital. Occasionally you'll see a baby born this way, or it could be a blunt force trauma or a penetrating trauma. This is a x-ray of a patient that we actually took care of about 3 years ago. A student was caring for a patient, and the patient was complaining of shortness of breath. They had just had a colonoscopy done, and they were kept in the hospital overnight while the patient was short of breath that next day. And so the student had talked to a physician and said, you know, my patient's really short of breath. And the physician said, well, it's probably just some atelectasis or deconditioning, because the patient hadn't been healthy for a while and hadn't been able to eat or drink. So they attributed the shortness of breath to being deconditioned and not up and moving very much. And thankfully, the student was pretty persistent and said, you know, this patient really just doesn't look good. There's something not right. So the physician gave in and got a chest x-ray, and this is what we saw. You can see the loops of bowel on the left side of the chest there. Those are all loops of bowel. Maybe a little bit moving over to the right side, but for sure on the left side. So what had happened with this patient is he had had a colonoscopy, and there was a misdirection and a tear through the diaphragm. So I'm not entirely sure how that happened, but this patient, they ended up taking to surgery and pulling the loops of bowel down to the stomach contents and then surgically repairing the hole in the diaphragm. So the patient did survive, but I was very proud of the student for being persistent and knowing that something was not right with her patient. All right, what will the patient feel like? I kind of described this earlier. The patient was significantly short of breath. They didn't feel well. They were nauseated and vomiting, and they attributed it more to the procedure than to actually looking into it. So make sure and get a good history on your patient and think about what other signs and symptoms you might see with this type of patient. All right, and then assessment and treatment. What do you need to assess? Obviously a chest x-ray, take a good history, and then what are some differential diagnoses for this condition? So think about all the things I've told you just in this case, and then come up with your own differential diagnoses for this condition. And then we talked about treatment, obviously surgical treatment or intervention for this type of condition. All right, thoracic or abdominal blood vessel injuries. Definition is any of the thoracic vessels in your abdominal or thoracic cavity. We are specifically going to talk about AAA or abdominal aortic aneurysm. For this course, this is where we're going to direct our our vessel injuries here. Causes can be blunt force trauma, can be stabbing wounds, can be just a congenital weakness, and then it happens to rupture. On this picture, you will see the descending aorta, which is what we're talking about, the abdominal aortic or aorta. In this case, this one has an aneurysm. So the bulge you're seeing there in the aorta is called the aneurysm. So sometimes patients just happen to find it, that they have an aneurysm, and that's just a weakness of that vessel wall. And so the blood pools in there, so they get decreased blood flow to their lower extremities, and this has a potential of rupturing. So we need to keep those things in mind when we are talking about your abdominal aorta. So we can have an aneurysm, a leak, or a rupture. So if we have a patient with a ruptured AAA or abdominal aortic aneurysm, and that has ruptured, what will your patient feel like? So write down some thoughts, see what you think about. Think about the pulses in their feet and legs. Think about their back pain. Typically, patients come in with excruciating back pain, and then you have to think about your differential diagnoses for that. So put that all together. If you have a leaking AAA, what might they do? So if it's just leaking, they're still in crisis, but they're not as bad off as if they have a ruptured AAA. And then if they have a bulging AAA, the rule of thumb is if it's 3 centimeters or more, they will typically do a surgical consult. But again, we have to think about elderly patients and if they'll survive the surgery, things like that. So with the bulging AAA, they'll leave it up to the patient and the surgeon to address that. And think about puncturing your thoracic vessels. So maybe a rib gets fractured and it punctures a thoracic vessel. So think about all of those things and what your patients will feel like if they have any of these types of injuries. And then think about differential diagnoses for these conditions. Assessment and treatment. So for your hemodynamics, what will the findings be for a ruptured, leaking, or bulging AAA or an injured thoracic vessel? So if you have a ruptured AAA, what will their cardiac output be? And if they have a, or think about their cardiac output, think about their blood pressure, think about their CVP, think about all of those hemodynamics with a ruptured AAA, okay? What else do you need to assess on these patients? And why do you need to assess that? So think about level of consciousness and then go on from there. And then how are you going to treat this condition? Obviously with a ruptured AAA that is life-threatening, they are at high risk of not surviving. So for a ruptured AAA, we need to get them to the surgical suite while providing fluids and blood pressure products to them right away to improve their survival rate. If it's leaking, we also need to provide fluids to keep their cardiac output up. And then for bulging, we need to get a surgical consult. Same way with an injured thoracic vessel. We need to think about where the site is punctured, how severe it is, and what the patient's signs and symptoms are. Thoracic duct injury, remember in our chest wall, that is where the majority of our thoracic ducts are, our thoracic nodes, our lymph nodes are. So an injury to that area can be caused, again, by radiation, by a stab wound, or by a blunt force trauma. Here's a good graphic of all of our lymph nodes, and you can see about the middle of the page, there's a green duct that is our thoracic duct. So that's the area we're talking about right now. So commonly, if you have an injury there, it's usually due to radiation or to like a Hodgkin's lymphoma where it gets so engorged that it may rupture or cause a leak in that duct right there. So the patient may or may not feel anything, depending on the severity of it. They may notice some swelling in their hands and feet or some ascites in their stomach because the thoracic duct is what takes all the byproducts that aren't needed and flushes them out the rest of the body. So if they don't have that duct to move that leftover debris, then they will see some swelling. But other than that, you may not see any signs or symptoms. Assessment on the chest x-ray, you may see an engorged mediastinal area, or you may see some chyle, C-H-Y-L-E. That is the debris that leaks from or that is flushed from the lymph system. So chyle may be seen in the mediastinal area. So think about some differential diagnoses for this condition, and then to treat it, again, we're going to go back to that 1 centimeter. If the injury is greater than 1 centimeter, they will take them to surgery. If not, they will just let the patient rest and give them as many fluids as they can to try to flush that remaining thoracic lymph duct debris through. Myocardial contusion, similar to a pulmonary contusion. Again, it's a bruise to the heart. There's your definition. Causes are typically an MVA, like a crushing injury to the steering wheel or a fall. You see elderly patients that come in and they have fallen and they may damage their rib cage and then causes a heart contusion. What will this patient feel like? Think about having a bruise on your heart. You may have some palpitations, you may have an irregular heartbeat. Think about your differential diagnoses for this. And then best thing to do for determining this is a good history. And then you also want to do serial EKGs on this one. So every 6 hours, they typically will get an EKG for 48 hours because this is one of those injuries that can progress over the next day or two. So you really have to keep an eye. Typically, they keep these patients in the hospital for 2 to 4 days to keep an eye on their EKGs to make sure there isn't any injury. You may see some ST elevation due to the injury around the heart, so keep an eye on that. Hemodynamics, again, depending on the severity of it, you'll have to, and where the area of injury is. So if it's in the left ventricle, think about what your hemodynamics will be, and then what else are you going to assess. And then as far as treatment goes, it's all supportive care. There's not a whole lot they can do, just monitor the patient and do those EKGs. Last one is cardiac tamponade. So cardiac tamponade is, you can see the good picture here, it's your pericardial sac becomes fluid filled, either by, usually it's a misguided line that's been put in and a vessel leaks into the pericardial sac. Viruses can cause it. There was an RT here in town a couple years ago that had a virus, and it kept causing her to have pericardial effusions or cardiac tamponades. So those are a couple things, but typically we'll see misplaced lines that will cause a vessel to leak into that pericardial sac. So the definition is the pericardial sac becomes fluid filled. Again, I've talked about the causes. Signs and symptoms, how will this patient feel? If your heart is not able to contract and expand due to excess fluid in the pericardial sac, how will this patient feel? So I'll let you think about that for a minute. A hallmark sign of this condition is called Beck's triad. You'll have a low blood pressure from the lack of cardiac output, so low blood pressure, muffled heart sounds because of the fluid around the heart, and then increased jugular venous distension because the heart can't contract and expand, so that blood will pool in the jugular venous area. Okay, so Beck's triad. Low blood pressure, muffled breath sounds, and increased jugular venous distension. So what will the cardiac output be in this patient if the heart is not able to contract and expand? And what will the blood pressure be? Think about your CVP. What will happen there? And then what else do you need to assess? Think level of consciousness. And then differential diagnosis for this condition. There's a couple that may mimic this. And then how will you treat this patient? So the typical treatment is a pericardial thoracentesis. So you won't do this, but a physician will insert a needle and let that fluid drain out of that. And it is immediate treatment, because if not, this patient will not survive because of the decreased cardiac output. All right, so can you identify the signs and symptoms of each condition described? Can you identify the treatments recommended for each condition? And then can you identify the chest x-ray markings or any other hallmark signs for each condition?